Today, we are discussing maggot therapy, a method for wound treatment and infection prevention that dates back centuries. The practice has received renewed attention in recent years, due in part to the growing threat of antimicrobial resistance. Hi, and welcome to Microbial Minutes. This is the American Society for Microbiology's update on what's hot in the microbial sciences. I'm Madeline Barron, Science Communication Specialist at ASM. What exactly is maggot therapy? Sometimes called maggot debridement therapy or larval therapy, the practice involves applying medicinal maggots, often belonging to the blowfly species Lucilia sericata, to wounds to promote healing. And it's worth noting that these maggots are not the same as those you'd find in the bottom of a dirty trash can. The larvae are bred and disinfected in a laboratory specifically for clinical use. Now, maggot therapy is primarily used for hard-to-heal or chronic wounds, such as pressure ulcers, diabetic foot wounds, trauma wounds, and others, when conventional therapeutic tactics fail or are unable to be performed for various reasons. It can also be used alongside standard treatment regimens to facilitate healing. In any case, during therapy, maggots are often confined in a dressing of some kind, and that dressing is placed on the wound for several days. Adverse effects as a result of maggot therapy are uncommon, though there can be some pain or odor. Now, when it comes to wound treatment, maggots have several beneficial effects, the first of which is debridement, or the removal of necrotic tissue and debris from a wound. Maggots do not have teeth. Instead, they secrete digestive enzymes that liquefy tissue for their consumption. They also mechanically dislodge skin via their body spines and mouth hooks. Debridement is often the primary reason for maggot therapy's clinical use, and there are plenty of data demonstrating its efficacy. Along with removing dead tissue, maggots also stimulate healthy tissue growth to facilitate healing. Lastly, maggots can kill microorganisms both by consuming microbes during feeding and by excreting and secreting antimicrobial enzymes. This is a critical aspect of maggot therapy, particularly in light of antimicrobial resistance, which can make controlling infection a challenge. Now, we'll come back to that in a moment, but before we do, let's take a quick look at where maggot therapy came from and its rise, fall, and ultimate reemergence in modern medicine. The use of maggots in wound care is really nothing new. Mayan tribes in Central America were among the earliest known users. Military surgeons in the 1500s noted that soldiers with maggot-infested wounds tended to heal faster than those without. Similar observations were made over the next several hundred years, and maggot therapy was first introduced into modern clinical practices in the 1930s by William S. Baer, an American military surgeon who noted the benefits of maggots for wound healing during World War I. After its introduction by Baer, maggot therapy became widely adopted in Europe, the US, and Canada. However, it fell to the wayside in the 1940s with the widespread adoption of penicillin and advancements in surgical practices. That changed, however, in the 1990s when, among other factors, the threat of antimicrobial resistance emerged as a critical issue. During this time, maggot therapy resurfaced as a viable method for wound management. And the U.S. Food and Drug Administration ultimately approved maggots as a medical device in 2004, making them available for debriding non-healing necrotic skin and soft tissue wounds. The therapy has since received greater attention from media outlets, clinicians, and researchers, with mention of its antimicrobial effects. Indeed, as discussed, maggots mitigate microbes via ingestion and secretion or excretion of antimicrobial compounds. Now, to that end, over the past 20 years or so, researchers have identified some of the antimicrobial compounds derived from medicinal maggots, and shown here is a small selection of those uncovered. One of the earliest examples, ceratacin, is notable for its antibacterial activity in vitro against a wide range of bacteria, including 12 strains of methicillin-resistant Staphylococcus aureus, or MRSA. Another, called MAMP, exhibited inhibitory activity against both standard and clinically isolated strains of S. aureus in vitro, presumably by disrupting the bacterial cell membrane. It also promoted wound healing in an S. aureus mouse skin infection model. Another study showed that antimicrobial peptides isolated from maggots, L-A-sarcotoxin and L-S-stamoxin, inhibited 90% of clinical multi-drug-resistant isolates of E. coli, Enterobacter cloacae, and Salmonella enterica, among others. In addition to these and other compounds, extracts of L. sericata larvae have been shown to disrupt bacterial biofilms, and their secretions and excretions exhibited in vitro antiviral and antifungal activity, including against potentially pathogenic species of Candida and Aspergillus. But what about clinical evidence for maggot therapy's antimicrobial effects? A lot of what we know comes from case studies. For example, a recent study published in the Journal of Wound, Ostomy, and Continence Nursing described the use of maggot therapy to treat a child with wounds colonized by multidrug-resistant Pseudomonas aeruginosa. Conventional treatments, including chemical debridement, negative pressure wound therapy, and antibiotics, were unsuccessful. Maggot therapy was started and continued for 34 days. Notably, after a single application of maggot therapy, one wound achieved complete epithelialization. That is, it was completely covered in new tissue, while the other 4 reduced in size by 70%. They closed completely with additional management methods like negative pressure wound therapy. Importantly, swab cultures of the wounds were negative for P. aeruginosa after treatment, hinting at the potential antimicrobial powers of maggot therapy. On a broader scale, a randomized clinical trial published in Chronic Wound Care Management and Research in 2020 explored the effects of maggot therapy in conjunction with standard treatments, including antibiotic treatment, on the bacterial burden of chronic ulcers. Treatments were completed for at least 3 weeks, with wound cultures obtained each week. Compared to patients receiving conventional treatments alone, those treated with maggot therapy showed improved wound healing and removal of necrotic tissue. Moreover, they had a significant reduction in bacteria within their wound, including decreased levels of S. aureus, E. coli, and P. aeruginosa. These findings suggested that maggots decreased wound bacterial burdens and that they may be useful as a complementary approach to standard wound management and infection control. However, in this study, the treatment was least effective against Enterococcus species, which coincides with other reports that maggots and their secretions may not work against all types of bacteria, though which bacteria those are can vary from one study to the next. With that in mind, continued investigation of the antimicrobial scope of maggots is warranted. Now, while maggot therapy is FDA approved, it's not routinely used, particularly in the US. And why is that? Well, researchers interviewed 9 U.S. health professionals familiar with maggot therapy to get their insights on the perceived barriers to maggot therapy use. The findings, published in the Journal of Wound Care, highlighted a variety of barriers related to the regulation, logistics, and perceptions of maggot therapy. Among other roadblocks, including lack of insurance coverage and accessibility concerns, the perception that maggots are gross was a chief concern. Though this study was small, separate surveys of nursing staff and members of the public yielded similar results. The yuck factor associated with maggot therapy is a primary hindrance. With that, experts highlight the need for greater education or re-education about maggot therapy's benefits, effects, potential, and applications. Wider willingness to use maggot therapy could jumpstart solutions to logistic and accessibility concerns. From a microbial standpoint, greater insights into the mechanisms underlying maggots' antimicrobial capabilities may inform and advance their therapeutic potential. For example, it may be possible to use maggot-derived extracts alone for disinfection and wound healing purposes. This would negate the need for maggots themselves, obviating some of the ickiness, while also being attractive from an antimicrobial resistance and infection prevention standpoint. Still, it's possible that a single maggot-derived compound or selection of compounds really isn't enough to achieve the full therapeutic effect. It's likely a combination of all the mechanical and enzymatic factors associated with maggot therapy that contribute to its efficacy. In other words, what makes maggot therapy yucky is also why it works. For some people, the alternative, that is, a painful chronic wound infected by antibiotic-resistant bacteria, really isn't much better. In such cases, maggots may be the lesser of two evils. And that's all for today. Don't forget to subscribe to ASM's YouTube channel and ring the bell to be notified whenever a new Microbial Minutes drops. I'm Madeline Barron. I'd like to thank you for listening and thank Ray Ortega for production, and I'll talk to you next time.